So there's a wonderful patient journey written by a psychiatrist who had anorexia when she was 13. And she wrote her patient journey in the BMJ and how she synthesized her argument. She said, I can use one word to describe my anorexia nervosa: isolation.
You have found the Thinking Mind podcast.
Professor Janet Treasure is a world-leading clinical and academic psychiatrist who specialises in the research and treatment of eating disorders. She is a professor of psychiatry at the Institute of Psychiatry, Psychology and Neuroscience, also known as the IOPPN. Professor Treasure has published over 300 peer-reviewed research articles and is the author of several textbooks and self-help books on eating disorders. She has been a member of the NICE Committee for the Guidelines of Eating Disorders twice and is a member of the Committee for the Marzipan Guidelines. Professor Treasure has pioneered a collaborative approach of working with both patients and their families and carers. Professor Treasure has been awarded an OBE for her services to people with eating disorders, as well as awards from eating disorder charity BEAT and the Academy of Eating Disorders, which is the leading international eating disorders professional association. Thank you so much for joining us. Today I'm hoping we can discuss the history, the present and the future of eating disorders. I'm hoping I can pick your expert brain specifically about the complex causes of eating disorders. I'd also like to discuss the impact of COVID-19 on those suffering with eating disorders and perhaps the effect of social media and diets, and a lot more if we have time. But first, I would love to know what inspired you to dedicate your life to the treatment and research of eating disorders.
Well, it looks as if I had a track going for eating disorders when you look with hindsight, but it wasn't really. But at school, I had a friend who was when she was about 16, developed anorexia nervosa. And we were all very surprised and puzzled by that. Medical school, I also had a colleague with an eating disorder, and I got the psychiatry prize as a medical student answering a question on anorexia nervosa. And then I applied to the Maudsley for a job when I was away on a sabbatical in America, and I was going to start in the September group, but I got rung up. Didn't want to do a locum with Professor Gerald Russell. So that was my first job in psychiatry, and I never really left. So it looks as though it was preordained, really.
And so you started your work, I'd say, in the last 20 or so years, but we know that the history of eating disorders dates back to the 15th century. Would you mind explaining briefly to our listeners the history of eating disorders?
Yes, well, there was a fight really between a psychiatrist in France who also wrote about anorexia mentale in about 1860. But it was Sir William Gull, a physician at Guy's, who called it anorexia nervosa and presented it to society meetings, and it got established.
And then a fair bit later, bulimia nervosa was recognised. Is that correct?
That's right. My predecessor, Professor Gerald Russell, made a very important seminal paper describing bulimia nervosa as an ominous variant of anorexia nervosa in 1979. So that entered the stage. And then there was concern and recognition that some people fulfilled the criteria of bulimia nervosa in that they had episodes of loss of control over eating and binge eating, but they didn't use the extreme compensatory methods that occur in bulimia nervosa. They don't purge, for example. But it took a while for that to be recognized as a separate syndrome. So it was just called other forms of eating disorder. But then eventually it was called binge eating disorder and accepted into the DSM-5. At the same time, there was major changes in the classification of eating disorders, and we took into the fold some of the childhood feeding and eating disorders. So ARFID, avoidant restrictive eating disorder in children, and also pica and rumination disorder.
And I know this is a difficult question to ask, and I can predict what your answer will be, but how common are these eating disorders?
Well, it depends which one, but bulimia nervosa is about 6%. All eating disorders with atypical Eating disorders is about 16%. Anorexia lifetime prevalence about 1 to 2%.
I think that's really high. I'm quite shocked to hear that.
Well, and yes, that is the case. It is surprising, isn't it?
16% is quite a significant proportion. What are the differences in between men and women within those categories?
Again, that depends on the age and the type of diagnosis. So in prepubertal males, there's a greater proportion are males, about a third, with anorexia nervosa. However, later on, again, a higher proportion of male have binge eating disorder in about 25 and above type age range. The binge eating disorder is often associated with different forms, where there's a drive for muscularity rather than leanness in the males.
Yeah, I was going to say, over time, I think the statistics have increased. And why do you think that is? Is it because we're recognising new types of eating disorders, or is it because of our environment?
I think it's a little bit of both, isn't it? So part of it is this recognition, and we're having all these arexias that the press has very creatively shaped, drunkorexia and diabulimia and I can't even think of them at the moment,
so many.
But there's a large number. Orthorexia is one that might get in there. So, you've got an alphabet soup of them. And indeed, there are many different forms. So Wolf said eating disorders have replaced sex as the neurosis of the 20th century, which might be true.
What do you mean by that? Can you just elaborate on that a little bit further?
Well, that food and what we eat and what it does to us, our shape and weight and our appearance are very pertinent to us these days, whereas sex isn't such a neurotic focus. It isn't, there's a pill, doesn't have as many tensions as, say, eating and weight does, the stigmatization of weight.
It's interesting you mentioned weight, and I do want to talk a little bit about later about causes, but a lot of people might think that anorexia only revolves around weight. However, in my short experience in working with people, it doesn't appear to be that clean cut. Would you say it's primarily surrounding weight?
Well, weight stigma is very key to bulimia nervosa and binge eating disorder, and perhaps less so for anorexia nervosa. But what we know is that the genetics, which is evolving and showing interesting things, is that we find a lot of transdiagnostic similarities across anorexia, bulimia nervosa, binge eating disorder, but there are polar opposites. So there's a link with BMI, weight, and with metabolism, which varies across the spectrum. So with anorexia, we have low BMI, insulin sensitivity. Binge eating disorder, we have associations with high BMI and insulin resistance. So there's a polar diversity in that metabolic genetic component. So these disorders are very unusual in that they're both psychiatric, with lots of associations with psychological disorders, but also associations with these metabolic variants.
Yeah. And I know you have particular interest in the research in the causes of eating disorders, and some of which include culture, early development, genetics, life events, personality, so on. What do we know about the type of life events that may lead someone to develop an eating disorder?
Well, the type of life events haven't been so well specified, but perhaps they're events that are social rejection events, and weight stigma sort of can precipitate that. So being bullied and teased about your weight and feeling alienated because of your body shape is very much a trigger for most people.
Do we know if there's a particular age range where that seems to be the most triggering for a development of an eating disorder?
Median age of anorexia is about 16 and bulimia is about 2 years or so later than that.
I've heard an argument that there might be some kind of evolutionary adaptive benefit of anorexia and bulimia. So let's taking anorexia, for example, one of the common consequences is that women who are anorexic stop having their periods, so that temporarily their ability to have children is ceased. And there's an argument that, for example, if a young woman is in an environment where she does experience those social rejection events that you mentioned, that wouldn't be a good time for her to have kids, and therefore some form of restricted eating might be a response to temporarily prevent her from having kids in that environment where it's not likely to be of benefit to her because she's not surrounded by positive social influences. And then when she does resume having a higher caloric intake, then she might be in a better position to have children at that time. And that partly explains why, and you can correct me if I'm wrong about this, but my understanding is that eating disorders typically only take place and found in countries with caloric-rich environments where actually there is the possibility of sort of resuming eating at any given time. Do you think there's much credence to this sort of evolutionary view of these disorders?
I'm sure that's right. I mean, we've got this polygenic array of genes, and it's very important for us as humans to adapt to our different environments and our different food environments. So the idea that people with anorexia are sort of very fit for being in famines and can, their overactivity will get them moving and searching for food. Then, of course, the people with binge eating disorder who perhaps overeat at times and store fat are very adapted to environments where there's a variety, there's fast famine and plenty. So I think probably all these adaptations help us, as the omnivores we are, to have successfully spread all over the planet and managed to eat wherever we are.
Does that answer your question? Do you want to ask anything else, Alex?
I guess it does. It helps to explain, because it seems at the glance, it seems kind of inexplicable, but it explains certainly even the psychological aspects, how, again, my understanding is a disruptive family environment is a potential trigger for the development of an eating disorder. And so it frames it less as this sort of inexplicable phenomenon. And that is why I like evolutionary views of psychiatric disorders and other medical problems as well.
Yes.
You start to understand not just the proximate triggers, but the ultimate triggers. And my hope really with these evolutionary understandings is they can actually decrease the stigma as well, if they're understood a bit better and brought more into the public consciousness.
No, I think you're right, because you explain the social environment, but there is also the eating environment. And there are variations. I mean, there's this naked mole rat where only one female is fertile and all the other females, a bit like bees, that's a type of thing. So there are various adaptations, aren't there, to environments. And so I think those two factors perhaps explain why we've got such of this polygenic variation.
And then on the flip side of environment is genetics. And am I right in saying we now know that there is a strong genetic link for most eating disorders? I think I read that there's a 58 to 88% heritability for anorexia nervosa. Is that correct?
Yes, it's about the same as a lot of psychiatric disorders, really, yes.
What are the most common mental illnesses that we see associated with eating disorders?
Well, depression and anxiety, but the one that's they're common anyway, but the particular one that has a peak is obsessive compulsive disorder. And of course, that fits so much with a lot of the phenotype that we see in anorexia nervosa. Whereas for bulimia nervosa, and particularly binge eating disorder, we get an increase in all psychiatric disorders. So we get substance abuse, alcohol, we get ADHD, impulsivity. The association is smaller, but more specific to those features.
And something I'm personally interested in is the link between autism and eating disorder, just because I've personally seen it quite a lot in my short experience. Is that something you'd agree with?
Yes, I mean, we do see it, and we're still trying to untangle it, because when you look at the polygenic associations and the family genetics, it's not that high. We do think that perhaps it leads to a more severe, prolonged form of anorexia nervosa, because the special interest can be focused on food, and the rigidity and wanting to follow rules. You can be a good anorexic if you have those traits. So whether it's that it just has a more severe form rather than an absolute increase in prevalence, the figures are very difficult to disentangle.
No, that makes sense. And I suppose it's fair to say as well, I think it's difficult to diagnose ASD, particularly in females. And is it the case that you've seen individuals that have presented with eating disorders which have led you to think and then led you to investigate and diagnose autism spectrum disorder in that individual or in individuals?
Very much so, because we know it's hard to detect ASD in females. There's a lot of masking some of the core symptoms because they can be more socially adaptive. And so it's very common that it's not picked up till later on. But then it is because a lot of the features of anorexia nervosa, the effect of starvation on the brain, is to make people lose their skills at social cognition. It makes them more rigid. So you get this pseudo autism, an effect of starvation. So disentangling the two can be difficult. And of course, often eating disorders present to adult psychiatrists, and we're not that good at, doing a developmental assessment, perhaps.
Yeah. I did want to discuss the effect of starvation and having an eating disorder has on the brain. Are you able to elaborate a little bit further about what happens really when you starve yourself?
Yes. Well, the brain is one of the most metabolically active organs of the body. So if you're starving it, it doesn't work very well. And of course, we as humans have a social brain. That's our main adaptation, isn't it? And so it does impact on a lot of social cognition. One of the things is another feature that's shared with autism is having a flat face, not showing emotions, a poker face, which can be extremely difficult because people find it very uncomfortable to be faced with somebody who doesn't emote. I mean, it's rather like, what is it? The valley. I've forgotten the term for it.
The uncanny valley.
Uncanny valley, that's right. And Gross has done a lot of work showing how it raises your blood pressure and makes you feel really uncomfortable. So that's one of the features. But we've looked at all sorts of social cognition, but also reading other people giving you feedback. That's always interpreted very negatively. So there are many aspects, and that covers part of the pseudo-autism as well.
Yeah, and I was just reflecting on that earlier because I was thinking it's not easy to recover from any mental illness. It's hard work to recover from mental illness. But if your brain is not functioning like it should do because you're starving it, it must be so much more difficult to process the information you're given and do the work in therapy. We'll go on to talk about treatment in a bit, but it must be so difficult to engage in that when your brain can't function like it normally should.
Well, I exactly see that point and think that that's why these disorders have such a persistent course. So, at 9 years, we still have 60% ill, and we have the highest death rate, we have a high suicide rate, hopelessness. So, once people are in it, they find it really difficult to get out of it. And as you say, it's these secondary effects that sort of can make people very stuck, because the organ you need to get out of it is poorly functioning because of the symptoms, as most other organs of the body, but that's the key one.
Would you say, you spoke about the low rates of recovery after 9-10 years, would you say that people, in your experience, recover, or would you say people learn to live with eating disorders?
It's a range, and some people do totally recover, and the recovery rates are higher for the binge spectrum disorders than for anorexia nervosa. But there's always a chance of relapse, but that's more rare. If people have recovered, they usually can sustain it.
Mm-hmm. You mentioned, and I just wanted to say that I think it's important that people know that it does have the biggest mortality amongst all mental illness.
Apart from opiate problems nowadays, I think.
Oh, really?
Yes,
Opiate addictions to opiates?
Yes.
Oh, I didn't know that.
Yes, I only heard it on an American webinar recently, so it might not have been appropriate for the UK.
And speaking of opiates, there does seem to be there is something about eating disorders that seems reminiscent of addiction, and one thing in particular is the way it simplifies your whole life. Like, I imagine what it might be like to be a young person nowadays, and life just seems so much more complicated. Maybe that's a fallacy, I don't know, but it seems like it is. And you know that eating disorders are prevalent typically among very perfectionistic people, high performing overachievers. Exactly. I imagine how complicated their lives must be, and to have everything like simplified to just the control of food and the control of food related behavior is similar to addiction, in that addicts often talk about, I'm currently working in an addiction clinic, and they often talk about how there's something calming about their life becomes just the ritual, relatively straightforward ritual of obtaining and using drugs. Do you find that with your patients, that there is that element?
Yes. Well, it's sort of, where is addiction, where is habit? Are they very different? And that sort of thing is quite interesting, isn't it? And of course, binge eating disorder has very much been classified as food addiction, but in anorexia nervosa, as you say, it's different behaviours that are repeated and comforting.
If I turn to on the flip side, we talk about habits, and one could argue that a diet is a habit. When does a diet become an eating disorder? Where is that line?
It's not totally easy to sort of differentiate, and it is a slippery slope, because you get people at all different levels of functioning. But we do know that it's very important that it doesn't go on for too long, because it does become embedded. So early intervention is really critical, because the outcome with early intervention is much better than if the illness is allowed to go on for longer than 3 years, for example.
And speaking of intervention, what are the current treatments that have the best evidence for eating disorders? I appreciate they might be different for the different types.
Yes, well, if we start with anorexia, because it's the oldest, treatment involving the family is very important for those who are still living with the family. And as I say, because they are an early type of intervention, they have good outcomes. We're much less certain about what really can help people who are adults with eating disorder. There are various therapy types, CBT. We've used mantra at the Maudsley, and there's an interpersonal therapy, but they're very similar in outcome. And so, there's a possibility that it's non-specific effects that are causing change. Whereas there's more evidence that for the binge eating type of disorders, CBT is quite helpful, but often you need emotional regulation help, and so DBT, compassion focused therapy, may be more appropriate.
And what about the evidence for medications in the treatment of eating disorders?
There is not very much evidence that there are treatments that work. So with Hubertus, I've just been doing a review of the update of medications. So there's nothing for anorexia at the moment. There is interest in the new treatments for treatment-resistant depression, because depression is perhaps a secondary consequence of starvation, and it doesn't respond to normal antidepressants at all. But there's, some little inklings that it may respond to things like ketamine or psilocybin are being thought about. And my colleague Ulrich Schmidt has used TMS and found that they improve in depression, and then later, much later by a year, there's some improvement in weight. So, that's a possibility, because depression is very much a feature of the illness, but, it's probably a secondary consequence. For bulimia nervosa, fluoxetine was found to be of benefit, but compared to CBT, where you get 40% recovery, it's only about 19%. But added together, sometimes with psychotherapy and fluoxetine, it can be helpful. For binge eating disorder, lisdexamfetamine has been used in America. It's not authorized here yet. And topiramate is another one that shows some benefit, but a very meager palette of medication.
I suppose it's a situation where you might as well try and see if it works.
Yes, and maybe you do need to make sure you're looking at the right thing, perhaps at the right time. So maybe you might get a reduction in the hopelessness that they have, and other features that's a depression, but it takes a long while for that to translate into weight gain. So, it is perhaps we've not been looking at the right thing at the right time.
You mentioned psychedelics. We're kind of dipping our toes in the water in the use of psychedelics in the treatment. Where are we at with the number of psychedelics? Are you able to elaborate on that a little bit further?
We're very much just starting little feasibility pilot studies. Mind you, there was a professor of medicine who looked after people with eating disorders who 30 years ago used ketamine infusions for anorexics that he thought the mechanism would be correct, and did find some improvement. So we will have to see.
No, it's still early days. One of the things that has really shocked me when I think about people that I've seen with eating disorders, and it's something that I don't tend to see, give or take certain mental illnesses, but the lack of insight, I find really, I was quite shocked by the lack of insight and really tried to understand it compared with other psychiatric illnesses. Do you agree? It seems very difficult for people that have an eating disorder, especially anorexia nervosa, to appreciate just how unwell they are, but also want to get better, unlike other mental illnesses where people that are depressed or anxious want to get better. I find very sadly those that are really unwell don't want to get better.
Well, there might be two aspects to that. One is this metabolic anomaly, the link with thinness and insulin sensitivity. And so the classical symptom, they'd say, is I don't suffer, therefore I'm well. That's what's the patients of Leseg, the French psychiatrist, noted. And so they don't get the consequences of weight loss that the rest of us, have. So that's one thing. And then, of course, what Alex was saying, the addictive aspects, the habit formation, the fact that, you're having to do this 3 or 5 times a day, so it gets really embedded inside.
Yeah. And then on top of that, like we said, if you can compound that with ASD, autism and other comorbidities, then it can just become more and more severe. You mentioned personality traits as well. I just wanted to go back, and we mentioned perfectionism. Are there any other types of common personality traits that you've seen?
Well, a sensitivity to anxiety, and also a tendency to constantly sort of see yourself as below other people, having social anxiety in particular seems important for anorexia, whereas for bulimia, binge eating disorder, there's some impulsivity there, etc.
One very topical subject that I wanted to discuss with you, and I know you've done quite a lot of research into this, is the impact that COVID-19 has had on those either suffering with eating disorder or vulnerable to suffer with an eating disorder that have gone on then to develop that. What have you seen in the past few years?
Yeah, so it has been this, this tsunami definitely has occurred in eating disorders, hasn't it? I mean, you hear eating disorder talked about all the time. And so that's fascinating, isn't it? Well, we've been seeing a gradual rising tide. because we talked about when did they start. So we had bulimia nervosa. Then from the 79 over the last 3 decades, we've had a gradual increase in bulimia nervosa and binge eating disorder over that time. But then we have had this huge surge. And it's very, it must mean that there are things in this environment that are triggering, mustn't it? So it's really quite exciting because it gives us a good chance to think about it. And of course, one of the key things, so there's a wonderful patient journey written by a psychiatrist who had anorexia when she was 13. And she wrote her patient journey in the BMJ and how she synthesized her argument. She said, I can use one word to describe my anorexia nervosa: isolation. So, this being cut off from other people and being like that. So, I mean, that was very much what lockdown did. And so the disconnection to the social network, is perhaps an important trigger or something that, or a social network can protect people from what goes on.
Yeah, and I suppose a home environment, I've heard you speak about in the past, that unfortunately when loved ones try and care for someone with an eating disorder, despite their best efforts, you can actually perpetuate the problem for the individual. Obviously some people can help, but unfortunately sometimes when you're trying to help, there are certain things that individuals do that can actually perpetuate that individual suffering with the eating disorder. Is that right?
Yes, well, it's, as you were saying, this puzzle of not wanting to change. So people with anorexia nervosa are in pre-contemplation. They don't want to change. So the more you tell them why they should change and what they should do to change, it goes over their head. So you have to use strategies that help people move gradually around and be very subtle to get to a stage where they want to change and are ready to do that. So we teach parents strategies such as motivational interviewing, which is very much used in addictions, because there is this similar ambivalence to change in addictions. So that's one thing that's helpful. But then another problem that can occur in all anxiety disorders is that family members just accommodate to the problem. So they end up sort of saying, I'll get a special sort of cereal. I'll weigh out your rice. Yes, you can do exercise. So they allow the eating disorder behaviors because the person looks so poorly, and you always do what somebody ill wants, and so it's a very natural response to accommodate. But of course, it allows the illness to stay, and often allows the illness to divide the family, because some people will be accommodating and being rather soft and letting people get away with only not eating their crusts, etc., or whatever we're going to say, whereas others sort of get so frustrated because it's so easy what you have to do. Why can't you do it? So it's just these strong emotional reactions, because we all have an automatic reaction to somebody looking so near death. It sort of terrifies us, and we can all vary in which way, and that's the problem, that families sometimes get fragmented by this.
Yeah, it must be so difficult because, like you said, we all have that natural human response of just eat,
Yes.
and it sounds so simple for someone who has a normal eating habit. But obviously it clearly isn't, because as we've just spoken about, the mortality and death rates and the low recovery rates is clear evidence that it's not that simple.
Mm-hmm.
Yeah, well, what you said reminds me of Karpman's drama triangle, where it's a piece of theory from transactional analysis, where if one person is in a victim ego state or a victim mind state, they tend to evoke one of two responses from people: either a rescuer who wants to dive into the problem and solve it all themselves, often sacrificing themselves as a result, or a persecutor who sort of is more judgmental and harsh in their approach. And this triangle, people, each individual in the triangle can flip from one state to another,
Exactly.
depending as the situation
Yes.
evolves. So I suppose as a family member or a clinician approaching someone with this kind of problem, you kind of have to step out of that triangle, don't you, and kind of
Exactly.
try to evoke the adult in them.
Yes, and that's where we first thought of these interactions in the family, was just seeing the interactions on our inpatient unit, because there we all get drawn into those triangular positions, as you say, and so we realize that this must be happening in families. It's such an automatically elicited response.
Yeah.
And it is interesting that understanding that and stepping out can be extremely helpful. And so training parents, giving them skills training and explanations like this. But I've never used that metaphor, but it would be a good one to use. I better get you to write it down for me.
How do you approach a new client? Say you have a new client walking through the door with anorexia, for example. What are the subtle things you might do or not do as you're talking to them, assessing them?
Well, you can't really use the traditional medical model of an assessment, what's your problem? When did it because they haven't got a problem, and they think, and so that's a bad start. So you have to go around. So you have to say, what are other people worried about? And then, are they right? And so you can gradually sort of get some relationship going. It helps if you know a lot about the medical consequences, the range of consequences of an eating disorder, because you can ask about all of those. And it's not that they will lie, but they might be they might not give you so many symptoms. So if you can explore those, you can eventually come up with some common ground that there are things that are going wrong, and they might want them fixed. So it's trying to use that motivational style to get there.
I was wondering if you have much of an opinion on the effect of social media on eating disorders over the past 10 or so years, how you think that's impacted all types of eating disorders, and how you think that'll impact the future of eating disorders as well.
Well, I think that there's no doubt that, that's one of the factors that have been causing this gradual rising tide of eating disorder. And it's particularly the objectification of us as human beings, and that our appearance is our main value and meaning in life. So that's really the crux of it. And so it is an important way of transmitting that idea.
Yeah, the idea that we all should lose weight, as in that's what we were told through the pandemic, and the government really went full on with that.
And they were so mean about people who were overweight who died in ITU, weren't they? So there's that. But it isn't, remember the men who want to be muscular, and they have eating disorders too. So it's the idealized form, really.
Are a particular gender or sex more difficult to treat with eating disorders?
I think we don't know enough about men with eating disorders, because there's always the samples are smaller, and sometimes they delay coming to treatment. But sometimes, they can be a little easier to treat. It's perhaps, for instance, testosterone might be used on men. It helps their bones and can help other things too. So, I think we just don't know. There's been so little investment into research in eating disorders. There'll be many questions you'll ask me, and I say out of knowledge.
No, I understand. It is a difficult situation, and I think my friend sent me an article yesterday, and I'm continuously sent articles saying, is this the reality? We've seen headlines saying patient with anorexia waits 2 years for a referral. Is that, and I find it quite difficult. I've worked on mostly inpatient wards, so I don't really know what to say to that. Would you agree? Is that the reality? Are referral rates ridiculously long? Are we really struggling at the moment in terms of services?
Hugely. People presenting in more severe states are often needing inpatients. Of course, we had...
And you mentioned early intervention is so important, so that...
And inpatient numbers, because of spacing are down and diminished. Day patients were all closed. So we lost our intensive treatments, and outpatient treatment was limited too.
Yeah, and in terms of funding for research?
Yes, I mean, you gave the example of autism, and it's about hundredths of what's given to autism and schizophrenia and things. But I think let's hope that NHS England and are giving a little bit more at the moment, and definitely putting a lot of investment into eating disorder training. But it takes a long while and a difficult track to get people fully qualified, doesn't it?
Yeah, I mean, talking about eating disorder training, I think what I've really struggled with, and I didn't know that I wanted to study psychiatry when I was at med school. I mean, in med school, you're taught about the health risks of anorexia. So you're told to look out for a BMI under a certain amount, and you're told to look out for a potassium that's low. But you never actually get taught about the psychological aspects of anorexia.
BEAT, I don't know whether you know, during the Eating Disorder Awareness Week, had a special feature on medical school teaching of eating disorders. But we do have a full curriculum, but it can get to every department in acute medicine.
What do you think the future looks like in terms of treatment and understanding of eating disorders after you've done so much hard work?
Yes. Well, we still need to get treatments for anorexia nervosa, so there's still a lot of work there. But these new things and being more flexible in our approach, which we always did have. I mean, because after all, one of the key studies was done at the Maudsley by Gerald Russell, the family therapy study, and was one of the first randomized controlled trial of a psychotherapy. People thought you couldn't do randomized controlled trial of a psychotherapy. So that was really very much a very seminal study. But after that, there was some work on bulimia nervosa, but nothing was focused so much on anorexia nervosa. And the trouble is that these are expensive studies; they take a long while to get better. So you need to follow them up for at least a year and that sort of thing.
Yeah, at the least. And what's been the most valuable or rewarding part of your career, given all of your work?
Well,
which is significant.
Well, the one thing that has really been of huge joy and productivity is being able to use participatory research, because I've written textbooks on eating disorders with people who've had lived experience, who are doctors. I've written the book for carers, somebody who had an eating disorder as a medical student. So we are very lucky to have a very helpful family and patient group who really want to work with us to try and help this disorder. And now, of course, we're encouraged even more to have such participation. But I would say that some of the work I've done with carers was very much developed with through the workshops. I wrote a paper describing inpatient treatment, and co-authors were all people with lived experience who are doctors or psychologists. So we were able to think about this: what goes on an inpatient unit, and how can it be harmful rather than helpful? So that has been phenomenal, and I think that's our hidden secret, that if we can untap that more, which we are able to do and encouraged to do in new research, we will profit from it.
It's interesting you mentioned you've written a lot of these with doctors and when you're at med school. I don't know, is there a specific statistic that you know of the increased rates of eating disorders amongst those in medical careers?
A colleague from Brazil was looking at that. So I think medical students are one group that seem to be at higher risk. Dietitians too, of course. But, there isn't so much data on it, really. But it is interesting that that there is a reduction in some of the stigma. It's not totally gone, that people are willing to be able to say, I've had an eating disorder, and be open about it. So that is a great step in progress.
Yeah, no, for sure. You just need to look on Twitter and you can see so many people that have had eating disorders that want to help other people, which is really good.
What are some of the biggest misconceptions do you think that people in the general public have about eating disorders?
Well, the main one is the stereotype, isn't it? The white, affluent, middle-class girls wanting to lose weight to meet standards. And what we know is prevalence of eating disorders is higher in Black and minority groups.
So a big stereotype about the demographic.
Yes.
The demographics that are affected.
That's right.
Thinking about the process of recovery is so interesting. One way I like to think about it, people present with all sorts of different problems, but one commonality I see is people have paradigm shifts as they go through their life. And in one sense, I think when dealing with someone with an eating disorder, I guess you're trying to facilitate a bit of a paradigm shift from, because if they're unwell, they're coming in the paradigm of, if they have anorexia, for example, I'm overweight and I need to lose weight. And that's kind of the mental prison, if you like, that they're kind of stuck in. And how do you facilitate a space where they can change to a different paradigm, which might be, I don't have the best relationship with food and my body, I have some sort of disordered relationship with those things. You did mention psychedelics earlier. We've talked about psychedelics quite a lot on the podcast. I think the interesting thing about them, there's been one study, I can't tell you exactly, but I'll put it in the show notes for people listening. One study which suggested that psychedelics can increase one particular personality trait in the big five personality, openness to experience, by one standard deviation. And I think when people are unwell, they're very rigid, and their thinking is often very binary. And maybe through that mechanism, through increasing of trait openness, perhaps that can allow this great flexibility of thinking and maybe to change their paradigm. Do you have any thoughts on that?
No, I think that sounds a good metaphor, and sometimes it almost happens like that, but it sort of just takes quite a bit of time because it gets so embedded with all these habits as well. And say, like for anorexia nervosa, it's not so much weight as the control of emotions, and sort of so what we try and do also is to try and think how else they can manage those things and what else can give meanings of value. And of course, because it's occurred at such a critical time window, they often haven't got the adolescent experience of trying all different sort of lifestyles. So that's the only one thing they've done. So it is hard.
Yeah, I've talked to people who binge ate, who said the act of binge eating is helpful for them because it's kind of, if they're feeling particularly difficult emotions, as you said, and you overwhelm your body with physical sensation. First, sort of the pleasant sensation of eating food, but then even the uncomfortable sensation, and it's all pushing the difficult emotions aside. And that's where you kind of, again, you understand the functionality of it for them, of the binge eating.
Yes, that's very much associated. Well, both for different reasons, habit emotional eating. The anorexia put all emotions at a great distance, whereas it's sort of managing very intense emotions more in binge eating disorder, because they've often had a lot of trauma in their lives.
And now there's the trauma is thought to underlie all sorts of different mental illness.
That's right.
Like depression, eating disorders, addiction, even psychotic. It's almost as if you have a genetic predisposition for one condition or another, and trauma is the environmental stress.
Yes.
Which activates that
trauma and your little bit of a metabolism genes as well.
Yeah.
Do you also see individuals that don't have a history of trauma but do still have a very severe eating disorder?
Yes, I think you don't see it as much in anorexia, perhaps. So it's not always the case, yeah. But there might be events, these feeling socially rejected that because of their perfectionism or whatever sort of seem much more important than they would to others.
Yeah, a magnified trauma, so to speak.
Have you noticed, does the change from being unwell more towards recovery, does it tend to be more sudden or gradual? Have you had any clients that had these sort of sudden moments of clarity, let's say, or these sudden epiphanies, maybe provoked by a particular major event in their lives?
Well, I think people do I'm not so sure if it's necessarily linked to an event, but they can, we get people describing their recovery journey, and they do say that they decided to sort of wrap up all their rules, to talk to their parents about the secretive things they were doing, and, can you help me change those? So, but it's still a bit of a rocky road because it's so embedded in a life pattern.
The whole process, it's not going to be an overnight change.
No, I mean, it does take, almost a year to recover with outpatients. And we know that inpatients, a large number relapse by 4 months, for example. And some of those just keep going in and out, which is very, very depressing for everybody.
Why do you think the rates are so high following an inpatient admission of relapse?
Well, because we're only treating the symptom, we're helping them managing weight, and we're perhaps not dealing with all the underlying things. And then often we perhaps haven't prepared the community response to give them support. I mean, we're just finishing a study where we've been given more support to families so that they hopefully can help bridge that gap. But yeah.
It's interesting. Just to say, for perspective, I was working on a previous ward during the pandemic with patients with eating disorders, and the pandemic meant that we couldn't have families come to the ward whatsoever, so we could do absolutely no family work. And you've said that it's so critical to have family involvement, and we were in a position where these individuals were suffering, and such a major part of recovery, their family input, completely gone. And how can you expect someone to be able to recover without that critical part?
That's right. And they couldn't go on home leave and things. I mean, we do family support, on Teams groups and that sort of thing.
Yeah, we were in a situation where we were having kind of Zoom meals, but I mean, that's just it was the best that we could do in a very bad situation, I suppose. And I don't know how helpful that was.
Yeah, and that's right. Meal support is totally lost on our inpatient ward because of the needing for distance.
Yeah, and I guess then the family feel helpless. Not to say they didn't feel helpless initially, but then they feel even more helpless. And then the individual might internalise that helplessness or hopelessness that their family felt, which can perpetuate the individual's feelings and emotions that perpetuate the anorexia itself.
Exactly.
It was such a difficult time.
And yet when they do recover, they're sort of wonderful people.
Of course.
The word of post-traumatic growth, as I say, that they really encapsulate that. And as you say, the way they're writing books, trying to help others or joining in, Beat has really profited by involving a lot of people with lived experience. And for our training, we have a large number helping with the training too.
Something else I think is actually really, really upsetting is, I guess this is an illness, a mental health illness that affects individuals in a critical age range where really they're coming of life. And I'm not to say that it wouldn't affect someone if they develop a mental illness in their 30s, but it's such a critical age range where you really are developing your, like you said, your personality and your building blocks for the rest of your life. And impacting that time period must be so destructive for those individuals, those young individuals.
Yeah. I mean, just a marker of that is that when we, just do routine descriptors of our patients, they've all got 2 years less education than the rest of the population. But of course, they do achieve well eventually, but despite the lack of education or sort of very limited education disrupted by the illness.
You mentioned that this was the average age was 16, a little bit different for bulimia, but anorexia 16. Do you ever see individuals develop anorexia or other eating disorders in later life?
Well, there is sort of interest that some people do seem to have. Perhaps it's a recurrence sort of later in life, is particularly at the menopause. And so some people wonder if the change in estrogen, that might be a bit of a trigger. And there's also the idea that some people in old age lose their appetite. And the people who get it in middle age often have had episodes of anorexia earlier. But that's not always the case with these older people.
Mm-hmm.
Originally, the original pre-DSM diagnosis was that you couldn't be diagnosed with anorexia over the age of 25. So we don't fully know. And definitely binge eating disorder occurs in the 40s and whatever. It can occur much later.
What do you think is the role of self-criticism and self-hatred in the development of these disorders? Thinking about both men and women, we talked earlier about how social media has been impacting things, and it's strange. I think we're at a very peculiar place in Western society where we're becoming ourselves are becoming commodified.
Exactly. Yes.
And I think we're in some very strange way. You see this with dating apps as well. We're starting to over-identify with different components of ourselves. So women might think they are their figure, or a man might think he is the width of his bicep. I'm not sure if you watched the movie Fight Club, but in Fight Club, the Brad Pitt character is saying, as men, you are not the contents of your wallet. You're not the possessions you own. And I think in the same way, people are starting to feel like their whole value is just based on these not entirely superficial, but relatively superficial physical characteristics, and that really lays, once you take away the notion of you have value inherently, you have value just because you are alive. It's very fertile ground for self-criticism. Then it's very easy to be like, well, he is more muscular than you, therefore you are insufficient, or she has the better figure than you, therefore you are insufficient. And it can create this mental pattern.
And it suits capitalism to get a market, isn't it? To convince you that you can do something about it if only you spend enough money and time on it, which often is not the right thing at all. You can't change these things. But it keeps the whole system going.
Yeah, it's a problem because it's like capitalism has become, it's risen to become our morality system and our ethical system. Like, I don't think anyone really intended for that to happen. It's more like the major institutions we had for morality before, which were like organized religion, have slowly degraded, and people's faith in them has degraded. And then in that vacuum, capitalism has just kind of filled that space. And now we're all kind of in this strange multi-million person experiment, seeing how that plays out. How do you play out if your sort of implicit morality and system of values is a capitalistic one?
Yeah.
It's terrifying.
It is.
It's terrifying. Yeah.
It's really scary. Ignorance is bliss, I think.
Yeah, but the people who are in charge aren't ignorant. They know all about us, more than we do. What we like and what we desire.
No, for sure. Yeah, social media platforms, they're completely conditioned to do that. And I suppose if someone's sitting there thinking, I want to be thinner and I want to control this, and you're just continuously fed images, it is terrifying.
Yeah, and so I guess there's something about like starting to recognize ourselves as three-dimensional human beings, and that there's that X factor. Like in the same way when you meet a person in real life as opposed to over Zoom, there's an X factor about them which you can't quite put your finger on. There's a magic, and in some sense I feel when you become really unwell with different kinds of mental health conditions, you stop relating to yourself as a person with that magic X factor, and you just see yourself as a pile of different flaws. So yeah, that's my random free associative rant for the interview.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.
If you're struggling with an eating disorder, speak to someone or visit beateatingdisorders.org.uk, the UK's leading eating disorder charity. Take care and thank you for listening.